So I was asked to do a talk on the new standards of care with regard to respiratory management of people with Duchenne muscular dystrophy. And they've been published very recently in Lancet Neurology, updated in 2018, and the information I'm mainly giving is a sort of another publication in the journal Pediatrics, and it's almost identical. In fact, I think it possibly is to what's in the Lancet, but I found it easier to read. It was bigger print in the journal. And one of the things I just wanted to highlight is the main emphasis or new emphasis is that we should be seeking to emphasize the need for anticipatory respiratory management before patients develop complications. So that's an overall philosophy that these new guidelines or care standards are recommending. And just to remind you, everybody I think knows here about Duchenne's, generally speaking, it's true, and we teach our junior doctors, if somebody with Duchenne walks into the clinic, is ambulatory, it's very unlikely they will have any respiratory problems. So the respiratory problems generally only start once somebody is largely becoming non-ambulant and using a wheelchair. So that's just a first principle. So if somebody can walk in, generally there will be no respiratory or major breathing problems. Now, I hope I don't insult anybody's intelligence, but I'm always aware there are patients and relatives come to this meeting, and I'm very keen to go through things very, very simply. And the obvious thing is we breathe for two things. Breathing is ventilation. You're getting air in and out. And we breathe in to take oxygen in, and we breathe out to get rid of carbon dioxide that's produced in the blood from our body, the metabolism. We need to get rid of it. And when we breathe in, our ribs expand up and out, and our diaphragm goes down. So the ribs come up and out, the diaphragm goes down. And the reverse happens when we breathe out. Our ribs come down and in, and the diaphragm comes up. So our lungs get smaller. So when we breathe in, we draw air in, and when we breathe out, we push it out. And everybody knows that. But if we have respiratory muscle weakness, which unfortunately occurs with Duchenne's, all the following things happen, and happen very slowly over time. And the first thing is we get hypoventilation. Hypo means too little, under breathing. And if you're under breathing, you almost certainly can't cough well. Okay, you get a reduced cough, because in order to do a good cough, you need to be able to take a big breath in and get air, and I'll show a little slide, a cartoon of that later. You need to get air in behind the blob of phlegm to be able to push it out, to cough it out. Simultaneously with reduced respiratory muscle function, swallowing becomes slower. And if you swallow, have difficulty swallowing, or you're forced to swallow quickly, you run the risk then of aspiration. And aspiration is where some food or something you've been eating goes down what our children called the wrong way. And that usually makes us cough and choke. But if you can't cough and some food or some fluid goes down the wrong way, it stays there. And that runs the risk of causing infections and pneumonia. And a third problem that occurs is when you've got some degree of muscle weakness of your spinal muscles, your vertebrae become curved, or scoliosis develops. And scoliosis is a problem which it seems to be becoming less now, but when your back and your spine becomes S-shaped, the actual mechanical way of expanding the ribs up becomes more difficult, because some of the ribs where they're joined to the spine it takes very difficult to get them to move. And if you have muscle weakness, the combination makes it your breathing even more restricted. So scoliosis is something we're very keen to try and prevent. And as I say in the slide there, steroids used in the right way, actually, in my impression over the last 20 years, is definitely caused a reduction in the number of people needing to go for scoliosis corrective surgery. So those are the general things that go wrong when muscle weakness occurs. But as it gets more and more, reduced breathing, reduced chest wall expansion, and reduced ventilation, we then develop where we're not getting enough oxygen into the blood, and where in the blood carbon dioxide isn't getting out. We're not getting oxygen in, and we're not getting rid of the carbon dioxide. So it gathers in the blood. The oxygen level goes down, the carbon dioxide level goes up. And now that doesn't cause an immediate problem. It comes on very gradually. So if I held my breath, I can only hold it for maybe 30 seconds, because after a while my oxygen level goes down, my carbon dioxide level goes up, and it gives my brain, the sensors in my brain tell me I must breathe. And you all know when you're underwater, you have to get up to get a breath of air. But if it comes on very, very gradually, the sensors in the brain get reset, and you don't have that feeling of I must get up and get a breath, which is a good thing. So initially, when respiratory muscle weakness increases and ventilation gets less, it comes on gradually, as I said, but the first signs of underventilation or hypoventilation occur at night when somebody goes to sleep. So whenever I go to sleep, my respiratory rate goes way down. And even I can remember sometimes my wife having to nudge me just to check that I was still awake, still alive, sorry, not awake. So your breathing can become at night very, very shallow. And that's because you're not actually doing very much. You don't need to get a lot of oxygen in because you're not very active. But if your respiratory muscles are weak, you can actually start to underventilate. And that can, in the morning when you wake up, you don't feel refreshed, you've got a headache, and then during the day you'll be tired and unduly sleepy. So your performance will go down if you're underventilating overnight. Simultaneously, you will have a reduced cough, and when the cough goes down, it first appears when you've got a head cold and you're producing more phlegm. And if you can't cough, you can't clear it. And a lot of children and people with Duchenne's will feel phlegm is stuck in their windpipe and they can't get it out. They can't get a good breath to get it out. And as I said before, a good effective cough requires a good deep inspiration to get air behind the phlegm in order to cough it out. So, how can we monitor? That's just the general things that go wrong with respiratory breathing over time. But how can we monitor for reduced breathing? And the first thing we can do is there's tests that can tell whether we have inadequate cough, and we can also do some tests to see if we're hypoventilating or reduced breathing, particularly at night. And these tests are generally in the group called pulmonary function testing, and overall they're actually a measure of muscle power in general, because most people with Duchenne's or neuromuscular conditions don't have abnormal lungs. Their lungs are normal, but the problem is the muscle power to get them expanded, to get them breathing in and out. So it's not lung disease per se. So we can measure how well you can cough by getting you to do what's called a peak cough. And that's just a very simple machine. You can see the peak flow meter here. My pointer's not working. Peak flow, and you just get the child or the young person to do a cough, as big a cough as they can into that. And the normal value of a peak cough, peak expiratory cough, is greater than 250 litres. And I've struck out the 250 litres because that's what I had when I was doing this talk last year. But the new guidelines have put 270, that we should be worried if the peak cough is lower than 270. And I'll be talking about the new guidelines. That's one area that I have slight problem with. But in general, that's how you do a peak cough. And you can use, if the person can't make a seal because of weakness around the mouth, you can use a face mask to get the peak cough done. Probably the single most important measurement is the forced vital capacity. And that's done using, that's a standard lung function, done using one of the spirometers, which is the machines now that we generally use. They're very portable. They can come to the clinic, or you can be sent round to the pulmonary function laboratory. And basically what it's doing, and it is a test of muscle power. I'm sorry my pointer's not working, but if you see the slide, I'm going to go over here. If you see this slide here, over here, the up and down, the sinusoidal breathing is what we call tidal breathing. So that's as you breathe in and out, it goes up and down. And then we get you to take a deep breath in to right to the top to fill your lungs up as most they can get. You can't get any more air into the top. And then there's a forced breath all the way down till you can get no more air out, and then you start to breathe normally again. So the vital capacity is this volume here. So it's the amount of air when you take a big breath in that you can actually get out. So that is your forced vital capacity. Okay, and that's the single most important measurement that we do. And it is in Duchenne's a test of muscle power. Okay, and I'll be talking a bit more about forced vital capacity in a minute. Now, those are the power tests, the peak cough and the forced vital capacity. We can actually measure how effective it is, because as I said earlier, we want to measure how well the oxygen's getting into the blood and how well the carbon dioxide's getting out. And there's very simple machines that do this. A pulsed oximeter, you just put a little probe over your finger and the reading comes up on the machine. There's actually little wristwatches you can put on and they record for 24 hours what the oxygen level has been without being required to be attached up to a machine. But what we typically do these overnight to see, rather than just a spot check, overnight to see what way the oxygen has been overnight. And here's a typical trace. I don't know whether you can see that well enough, but on this axis here is up to 100. And the normal oxygen overnight, what we call the basal level, should be over 95. And it should rarely, if ever, go below 90. And you can see in this particular person, there are big dips away down into the 60s and 70s. Then it's back up to 95, then back down again, and back down again. So by doing this overnight, we can get an idea of how well the person, the child or the young person, is oxygenating overnight when they're asleep. And as I say, when you're asleep, you tend to reduce the amount you're breathing. And you can see the heart rate trace done at the same time. So that's oxygen, can be very easily monitored. The next thing is carbon dioxide. I said we breathe in to get oxygen in, we breathe out to get carbon dioxide out. And there's two general methods that can be done. You can get a blood test, of course, for these, but not many people, like certainly children, I'm a pediatrician, don't like getting their blood tested. And we certainly think if you make somebody anxious and worried, they start to breathe more and they may actually normalize things. So we tend to do, one is transcutaneous carbon dioxide monitoring. And that's where a little probe, you can see the boy here, a little probe is put onto the skin. More commonly we use it on the earlobe. It's put on and it monitors the carbon dioxide in the blood coming up to there into the skin, and it is recorded on the machine, and then that's printed out overnight. And that's what we do in Belfast in Northern Ireland. Some other units would use the end tidal breathing, and end tidal, as I said, tidal breathing is where you're breathing in and out, and at the end of breathing out would be where the carbon dioxide would be peak. And it's measured just by putting a little probe near the nose and measuring the carbon dioxide at that probe. And you can see the trace here. So this would be the end. So when somebody's breathing out, it'll come here, and the carbon dioxide levels will go up. Sorry, can you see that? Can't print there. You maybe can't see this, but the end tidal is the point D here of carbon dioxide, and then when they start to breathe in, it goes down again. And that reflects as a good measure. We've tended to go by the transcutaneous, but we've got both, but we find the end tidal overnight often gets dislodged, doesn't work, gets steamed up and hasn't been recording just as well. So we've had more success and tend now just to use the transcutaneous CO2 monitor. So those are the ways we can measure the effect of breathing. And there's another example of somebody at the top of the screen. sorry this doesn't point, you can see the oxygen levels with the dips, and in the bottom trace across the bottom is the carbon dioxide level, and you can see the spike ups in carbon dioxide when the oxygen dipped. So those are episodes when the person doing this, they weren't breathing adequately. And then you can see after, when they were started on non-invasive ventilation, the oxygen level stabilized out and the carbon dioxide came down with no spikes. So that's monitoring oxygen and carbon dioxide. So what's the natural history now from a respiratory point of view of Duchenne's if no action is taken? And the whole emphasis of the new guidelines is that we anticipate and start things early. So I've mentioned to you forced vital capacity, and you can see quite clearly it reaches a peak. I always regard it as reaching a peak when somebody is about coming non-ambulatory. So if a child walks in with Duchenne, typically I feel they're going to have good lung function and it's possibly going to rise. But once they're starting to become non-ambulatory, I feel they're at the peak of their lung function, their FVC. And that's usually around the ages of between 8 and 12, and it varies between patients. And thereafter, there is a steady decline. And you can see the steady decline going down. And I've put the different phases, the ambulatory, the early non-ambulatory, and the late ambulatory, coincides with lung function deterioration. And one important fact that I only became sort of more aware of when I was talking a year or two ago to the company that's doing idabendone, the drug that helps nutrition of the muscle cells, and some government agencies like to see when they're approving drugs that it in fact improves people's quality of lives. But in fact, there is a silent period when somebody is is non-ambulatory, using a wheelchair, and their lung function is steadily declining. But because they're not walking, they're not becoming short of breath and not becoming aware that their lung function is declining. So it's what I call the silent deterioration zone. And it's why it's so important also to regularly be monitoring, to anticipate when a problem is going to occur. So that's what I call the silent zone, when the early non-ambulatory period, when the FVC, the lung function, is declining, but it's possibly unknown to people if you don't measure it. And then there's an initial later phase where initially, as I've said earlier, the patient gets a problem, particularly at night, with hypoventilation and maybe getting headaches, unduly sleepy during the day. Performance goes down because of these desaturation episodes and hypercarbia, too high CO2 during the night, but okay during the day. And also simultaneously, they will have a problem with coughing, particularly when they get a cold. And if you can't cough and you've got phlegm there, you're much more likely to get a blob of phlegm blocking a tube going to one section of the lung, and then that will collapse, or to get pneumonia, to get infections. So coughing is equally important. And then eventually, as time goes on, these problems with difficulty getting your lungs to expand occur both during the day and the night. And when we see people who are in this position, hopefully they will be put on NIV and cough assist well before this occurs. But typically when you try to measure somebody's lung function, their chest wall doesn't expand, okay, and the shoulders go up when they're trying to blow into the machine. But hopefully we will have people onto non-invasive ventilation well prior to that. But this slide, these last two slides, I think, really highlight the importance of regular monitoring lung function. Can you see these slides okay? They look very, and I'm sorry I can't point to them. What I just wanted to, a very good recent study just highlighted and really stresses to me the importance that children with Duchenne's come to see a respiratory person to get their lung function measured from the age 5, 6, and 7 onwards, maybe annually. This first slide on the left here shows that if you become non-ambulant early, so say between 8 and 10, your lung function, the bottom of those lines, I'm going to show it over here. The bottom, you're likely your lung function will never peak as high and will drop down quicker than if you're in the blue zone and you're ambulatory to say age 14 to 16, your lung function will get higher and then you will start to decline thereafter. But you will be starting from a higher level and you will be older. Lung function is actually it's just saying it's a measure effectively of muscle power. The second thing is, and it's very convincing, the effects of steroids. Steroids seem to undoubtedly, and that's the middle of these graphs, seem to extend the time when somebody is ambulatory, extend the time for them to get a higher peak, and then the fall comes afterwards. The rate of decline is the same, but it's occurring later and often from a slightly higher position. So steroids, I think, undoubtedly, and I have seen this over the last 15, 20 years, undoubtedly made a big difference. And the final slide is just a slide of the drug ibiprazole, and this is just from one of the studies done in children who couldn't tolerate steroids, and it's had a similar sort of effect of not changing the slope, the rate of decline, but extending the period by a year or two as the decline, before the decline went down, like the steroid effect. So those are the effects on the natural history of those particular drugs, and also how severe your original muscle weakness is. So these new guidelines, we seek to emphasize the need for anticipatory, so that's knowing before the complications occur, requires regular monitoring. But we want to put timely interventions to prevent respiratory complications. So the next question is, what can we do? And the new guidelines are saying that when somebody's forced vital capacity is less than 60%, we should start lung volume recruitment. And by that, what typically is done is a physio with an ambu bag and a mouthpiece will push air into the lungs several times a day to try and get the lungs expanded. A bit of a way to think about why do you need to do lung volume recruitment. If you sat, people without Duchenne's, if you sat watching a big long film and you were in a settee and you're slumped a bit, and the film was War and Peace, say, that lasts 4 hours, and you would, if somebody put a video on you, you would be every so often doing a deep sigh, a big, okay? And that's a reflex that we have to expand your lungs, to expand the lower part of your lungs, because when you're sitting slouched and not doing big breaths, it tends to collapse down and you try not to. So doing lung volume recruitment, getting the lungs expanded twice a day seems to be helpful. And what is new in these guidelines, and this is one of the things that we have realized that we haven't in Belfast been doing, is that at a much earlier stage are we doing lung volume recruitment. I just want to highlight there is an excellent, if you want to see, there's an excellent website that has videos of these at the CanVent Ottawa website. It's in the guidelines. They recommend looking at it, and it gives the videos of how to do all these procedures. So that's the first thing. Physios should be starting lung volume recruitment. The second thing is the guidelines are saying if your forced vital capacity is less than 50%, or your peak flow, and I have a wee problem with this and I'll explain that later, is less than 270, cough assist should be started. Now, cough assist is very similar to the previous thing, and lung volume recruitment can be done with a cough assist machine. And what it basically happens is, what you're wanting to do is there's a blob of phlegm in the airways. We're wanting to get air in behind it, behind those blobs of phlegm, in order to be able to, when you breathe out, to get the blobs of phlegm out. So with cough assist, the machines, you can see a picture of one here. What it typically does is a face mask is used, it pushes a pressure in of air of, say, a pressure of plus 40, and then it moves it out to minus 40. So there's a big change. It's pushing air in, hopefully behind those blobs of phlegm, and then going the other way to try and help come it out. And a physio can do that to try and help get rid of phlegm. And certainly the cough assist devices, whenever we give one to a patient, they will never give it back. They feel it's a real godsend, very, very useful device. And I'll be talking about how to get those, or how we've had a problem with that. But cough assist needs to be started. The guidelines are also saying, and this is something we haven't been doing in Belfast, so it's where we're now starting to have to change our practice, but they're saying that patients who have a cough assist also need to have a home oximeter. That's a wee measurement that you can measure the oxygen, so that if you have a head cold and your oxygen saturation is maybe dropped, or if early if you're having difficulty coughing, that you can increase the frequency of using the cough assist to try. And the feeling is that this would prevent a pneumonia, prevent a lung collapse, and likely prevent hospitalizations. So the earlier use of cough assist and having an oximeter just to be able to monitor things is one of the recommendations in these guidelines. The other thing that we can do is we can check to see, as I said, if there's nighttime hypoventilation, if the carbon dioxide's at night, and we can then give breathing support. Now, breathing support, people think that's taking over breathing, but it's not, because people with Duchenne's, when you start non-invasive ventilation, if they don't use it tonight, they've no problem with breathing. It's supporting breathing. It's adding to each breath. So the typical non-invasive ventilation machine, you can see somebody here, it's called BiPAP. It pushes in air whenever the patient triggers a breath. So the patient starts to breathe, and as soon as the machine sees the breath coming, it pushes some extra air in and then lets it out. It doesn't let it go out fully. It keeps a wee bit of an end pressure. That's why it's called two-level pressure. So it pushes in maybe 12 or 15 pressure, and when it comes out, it leaves it at, say, 5 or 6, so that the airways don't collapse completely down. That's why it's called BiPAP, bi-level positive airways pressure, or non-invasive ventilation. Okay? But it makes a vast difference putting somebody onto it at night. So it's supplementary breathing. It's not replacing it. It's triggered by the patient. There's a backup rate just in case the patient were to breathe very, very, very shallowly. And it makes a vast difference to performance during the day. And as we all know, when we've had a terrible night's sleep, you don't perform as well the next day. And if patients who with Duchenne's who are under breathing at night, actually doing that will make performance much, much better. And I can remember one of the very first young people we put onto non-invasive ventilation. The teacher, a week or two later, said there's a new boy in the class, which just shows you the effects of that. And finally, with respect to non-invasive ventilation, and again, I rarely have to do this because we've now got a transition service. We're transitioning people, so a lot of adults are now, if they need to have some support during the day, there's the Sepa Ventilation, which is a little probe that can sit beside you, and you just put, so obviously to speak or to shout, if you happen to be a manager, if you're Duchenne's and were a manager and you had to fire somebody, you need to be able to get a breath in and then to be able to talk out and then get another breath in. And Sepa ventilation seems to be, to me, very, very good option. We have tried it twice in the Children's Hospital in older teenagers, but haven't been successful at getting them to take it. But I'm aware of people from the Republic of Ireland, I don't know about how often it's used in England, have had great success. But we've now a transition, and it's going to be our adult team that will be dealing with that. So one of the new recommendations in the new guidelines are that when respiratory function is reduced, to the extent that NIV is started, a new recommendation is that cough assist should be started at the same time. And that's very, very logical. If you can't breathe enough that you need to have support to get your nighttime breathing right, you almost certainly can't breathe enough to cough adequately. And one of the good features about guidelines is we've had a great difficulty in Northern Ireland getting cough assist. We've never had a problem getting NIV, the machines to do non-invasive ventilation. It seems that there's a budget there and it seems to be okay. But you see, when we come to apply for a cough assist, there's a huge problem. Nobody seems to, there doesn't seem to be any budget. It goes, we ask the nursing community budget, it's not theirs. They say it's the physios say they have no budget. The hospitals say, but we can't pay for people from a different trust and we need it back. And it causes a major problem. When these new guidelines came out, we looked through them, we saw this, we thought this was very logical. Cough assist should start at the same time as non-invasive ventilation. And we sent that to the Department of Health in Northern Ireland. They, for some strange reason, seemed to buy it, and they've given us some resources to help us immediately to be able to provide cough assist when we need it. And we reckon there'll be 4 or 5 children every year get to that stage for our population. And they've also started talks about how to get a long-term solution for both children and adults. So the actual guidelines, giving them the guidelines, the recommended statement saying we can't meet it, we have this problem. Certainly in Northern Ireland, action is being taken is a better way to describe it. So that's to do with ventilation. It's very important when you're talking about respiratory health just to remember if swallowing is becoming a problem, so somebody's slowing down, taking an awful long time to eat, and somebody's pressurizing them, there's a good risk that they could aspirate, and that's not a good thing. So you can get speech and language therapists to do directly observed feeding, and they can do a video fluoroscopy, which is seen what's the risk of aspiration. And you can see in my slide here, normally the contrast should come down the esophagus into the stomach, and there's some that has spilt over into the windpipe. And food going down into the lungs is certainly not a good thing, and something we would definitely try to avoid. And that therefore means that sometimes if that's happening, people sometimes need a nasogastric tube or a little peg tube inserted here. And it usually horrifies young boys and also parents when we suggest that, but almost always when it's done, it's been really a brilliant success, and it's unseen and generally doesn't cause a huge problem. Another thing that's very important is to try and prevent infections, and the annual flu jab and making sure you've got your vaccinations up to date are very important. So, just to go back to the guidelines, we seek to emphasize the need for anticipatory respiratory management before the development of complications. And these are the algorithm that we're trying to follow now. I realize you can't see it that well. In the light green box on my left, which is your left as well, if I'm looking around this way, is ambulatory. And the first line says annual Fvc measurements. And we're trying to do that from the age of 5, initially to get practice so that the children can learn how to do it. But it also tells us, as we follow them up till they're age 8, 9, 10, 11, where their peak is going to be. So we think that's very important. If the second box is if they've got obstructive sleep apnea, so snoring and maybe having difficulty breathing at night, you should do the overnight oximetry and CO2 monitoring early. And then the middle line is for early non-ambulatory. And that, what we try and do is at that stage start seeing people coming to do their lung function, their FVC, on every 6 months. So that we can monitor the decline, we know when the decline's occurring, and that we can monitor it more closely. You're meant to start doing oxygen overnight and CO2 monitoring. And that is another little area that we are going to have to tell our Department of Health that we can't do. We currently, to measure in our unit in Northern Ireland, we currently have a waiting list of almost 8 months. and we therefore cannot, by definition, do people 6 monthly. And the waiting list is heading towards a year, and that has become a big problem. So we're going to have to highlight this problem so that we can get that done on a more regular basis. The guidelines further down give the points where cough assist and non-invasive ventilation should be started, and they're definitely suggesting they're started together and started slightly earlier than we previously would have done. So when the FVC is down to 50 to 60%, that's when the indications are that we should be thinking about starting cough assist and non-invasive ventilation rather than waiting. So the things in these new care considerations or guidelines that we think are going to affect us is, as I've just said, cough assist at the same time as non-invasive ventilation, start volume recruitment physio cough assist at an earlier age, and the same with BiPAP at an earlier age. And we want to be sure that we're making sure everybody is getting on this anticipatory pathway, that they're being monitored, and so that we can prevent complications occurring. So that's, and I hope I haven't insulted anybody's intelligence. I'm happy to take any questions. And that's, again, the video the website that I think is very, very good. Thank you. It's much, much easier and cheaper and very easy to measure oxygen. So if we're doing the oxygen measurement, we can put the little wristwatch onto you, we can put the wee probe, switch it on overnight and measure it. Or we can do it, if you came to the clinic now, we could do it and get a one-off now. The carbon dioxide one is technically harder. The machine is bigger and much more expensive. So the little oximeters cost £500–600, maybe £1,000 for a good one. The carbon dioxide ones are a lot more expensive. We initially, that transcutaneous one on the earlobe, we initially started to do it at home, taking the equipment, the nurse would take it out, but the machines were breaking and we couldn't afford to replace them. So there were those two issues. So to do carbon dioxide, currently our practice, I know other units may still be doing them at home, we have to bring the person into hospital overnight. And there's a big problem with doing it in hospital overnight is I don't think you sleep as well. If you're in hospital, it's not the same as being in bed at home. As simple as that. So the carbon dioxide measurement has more problems than the oxygen. But it's a very good question, and I think as technology improves, I've seen one of the little pulsed oximeters that does them both together, and I presume that type of technology in the next 5–10 years it'll become easier to do. But that's a key question. Well, how is it in Northern Ireland? We're not privileged, I don't think at all. When we started non-invasive ventilation, we had a problem. This would be 10–15 years ago, but it very rapidly was accepted. The community of people with Duchenne's and spinal muscular atrophy pushed for it, and the Department of Health allowed it, and it just gradually came on. And so we've never had a problem with the budget, but we at the minute have a big problem with cough assist. Nobody seems to say it's their responsibility. Nobody wants it to come out of their budget, and there's maintenance costs for the equipment as well. And our Children's Hospital in Belfast have been providing them for people all over Northern Ireland from charitable we're having to go request them from a charity, a hospital charity to get it, and we feel that's not satisfactory. So that's why when these guidelines came out saying it is totally illogical to do non-invasive ventilation without cough assist, we took it to the Department of Health, the Health Promotion Aid, and I got a phone call about 2 weeks ago saying they were going to provide resources for anybody that we had now that needed them, and in the next year, and they were going to have a series of meetings to try and get a sustainable way so that they would be rented with the backup if something went wrong, they would get serviced and so on. So I couldn't say we are better off than anybody else, because I suspect it's different areas. I don't know the extent of the problem in England. I don't know, or Scotland or Wales. Where are you from?
I'm from Estonia.
Estonia?
Yes.
Yeah, you're
and we have quite
good English.
And we have quite same problems that
the same problems.
Yeah, that VPAP is available, but not cough assist.
Yep.
Yeah. Thank you.
Well, that's where that's exactly us, and I'm sure that's the same everywhere. I think there's a clinical trial currently going on comparing the standard dose of prednisolone with 10 days on, 10 days off, and also with a different steroid called deflazacort. Deflazacort has been used for a long, long time. It was marketed 20 years ago as being as good as prednisolone, but with much less side effects. Now that marketing had to be changed because it does seem to have some side effects, but to me it doesn't have as many, okay? But we used to use it, a lot of my experience has been dealing with other respiratory conditions, such as asthma, and we stopped using deflazacort for acute asthma to damp down the inflammation, because it did not seem to work in our experience as well as prednisolone, okay? Now, there's been quite a big study in the USA looking at deflazacort, and it seems to, in Duchenne's, because you may not need the big potency dose of steroid to damp down the inflammation in muscles, as you do with, say, something like airways inflammation and asthma, okay? So the studies have suggested that deflazacort, which seems to definitely have a slightly better side effect profile, works well in Duchenne's. And I know that in the States there's been a big problem since that was published and the FDA licensed deflazacort, because the company, I think prednisolone costs almost nothing here, and deflazacort's just slightly more expensive. But the company that manufactures it in the States put up the price by 1,000-fold as soon as the FDA approved it. And we have had families who have had connections to Northern Ireland come back over to try and get it at our price, because clearly I think you have to pay for it over there. But I think until these studies comparing, because you don't want to be using something, I suspect it's going to be as good. I don't know for sure, but there is a study which I don't know the results of that compares standard prednisolone, 10 days off with 10 days on, and deflazacort. So I can't really give you an answer to that. Here, we might get from an endocrinologist.
I was just making a comment. So that might not actually answer your question, because the 4DMD trial is actually, I think, about the first 3 to 4 years of starting steroids. I think your question is whether there's a difference between steroid regimen and steroid type on future lung function. So I think 4DMD will answer some questions about the initial muscle function, but it may not actually answer question about respiratory issues, because it's in the first few years of starting steroids where, as we already heard, that might not be an issue with lung function.
So it might be many, many, many years where you can compare the two groups. So that'll not answer it either.
No, so the 4DMD trial is only at start of starting steroids. It's randomized to 3 different regimens. So young boys won't have respiratory issues. So they might be collecting respiratory function. I don't actually know the specifics, but you might actually see no difference because you're not.
And it might take 10 or 15 years before you see the profile. We faced that problem in Northern Ireland. There was a period of time, maybe 15 to 20 years ago, when there was the neurologist. We had a single neurologist, and they had retired, and there was no replacement for 4 or 5 years. And that was when steroids were starting to be used. And what got me interested in Duchenne's was I started to get children referred to me by the orthopedic surgeons to do lung function before they corrected their scoliosis. And then when looking up, I suddenly realized none of our children were on steroids, and the preliminary evidence was suggesting that would be beneficial. Now, we started them whenever we got, the one retired neurologist was replaced by 5, by the way, in Northern Ireland, but we then started the people who were quite late onto steroids. Now, I couldn't say, and we put them on steroids and on bisphosphonates as well, because there was a paper from Canada suggesting the combination was better than steroids alone, but I can't say that I could say that was a good thing or a bad thing to do. We did it, but I couldn't say, because I think the most benefit from steroids is from that 5 to 12 age group. But we don't stop it. I don't know what other people do. We don't stop it at age 12, and we probably would start it in somebody, say, 12 or 14-year-old who hadn't been on it. We would start it. I don't know about somebody who was 22 or 23. Could I ask you that?
Me?
Are you a physician in Iceland?
I'm a physician, yeah.
Could I ask you to answer your own question? See what you would say.
I'm not sure what I would do, but I think I would try steroids.
Yeah.
Because there is nothing else to do.
Yeah. We've used the idobendone, Raxone in people who haven't been able to tolerate steroids. Okay. Well, thank you very much.